All right, we have a quorum. Thanks for investing some more time, folks. This will be the last meeting of this type before we file the final rules. We have some time as we go throughout, and we have a lot of stuff to discuss today, so let's go ahead and get started. Hopefully everybody had a chance to look at the minutes from the last meeting. So we'll start with a motion from the committee to approve the minutes from last month's meeting. Yes, and a second. Any further discussion? Okay, all those in favor, please say aye. Aye. Any opposed? Anybody not voting? Okay, let's jump right into it. We've got 80 minutes on the agenda to talk about the final draft rules for public comment. So that'll take us up till about 10 after 5, and the remaining time will be spent on public comment from the floor, and we'll organize that at the end of the 80 minutes. If we need 80 minutes, we'll take it. If we get done in 60, we can have more time for public comment, but I would, out of respect for everybody's schedule, like to exit at 6:30 so that everybody can get back to their families, etc. So let's go ahead and let me just frame the presentation and frame the process for those to refresh everybody's memory. We've been through a long rulemaking process. We've had about 3 or 4 different drafts, some of them informal drafts. This is our most formal draft set of proposed rules. Having said that, this is what we call in the rulemaking process the final draft rules for public comment. So this is the final opportunity for public comment, both from the committee and from the public. And then what we'll do, given the input that we get from the committee today and other input that we have been getting throughout the last couple of weeks, is to put together the final set of rules that we will then publish on our website probably towards the end of June. I think the last window of a workday is the 27th or 28th, which is the end of June. I think we'll probably be finished making substantive changes after the first couple of weeks of June, and then there's a lot of periods and semicolons and that kind of stuff that we need at least a week to do, because once stuff goes into the Secretary of State's office, you can't even change a semicolon. And these rules, whatever we file, are probably going to be there for a long time, so we want everything to be right. So that's where we are in the process right now. Any questions from the committee about? And we're going to try to keep that on the mic, because the people on live stream can only hear if we're on, so we'll do this passing thing.
So the question I have is, we got a draft rule that came out May 24th, right? And now we have a PowerPoint presentation. So is this PowerPoint presentation a draft rules? No.
Yeah, good question. So the PowerPoint presentation is not a draft rule. It's just a tool that we put together for discussion purposes. The draft rule for public comment that was posted right before that 3-day weekend, let's say it was the 24th, that is the official document, that the draft rules for public comment. The PowerPoint presentation that we're going to go through in a few minutes represents the content of those rules, plus a few changes that we've made given the public comment that we've gotten over the on the blog and other places regarding the testing, required testing, whether that's a physician consultation or whether that's a prohibited practice, those kinds of things. So there are a couple things that Kara and Tom will talk about it. When you see the PowerPoint come up, there'll be a couple elements that have been altered a little bit since the 24th draft. But there is no official draft that's been posted after the 24th. The last final draft will be the thing that gets posted towards the end of the month.
Okay, we're good. All right, so as Will said, these are going to contain every section except for time frames. So we're going to go through section by section, and the changes that, this isn't the change from the most recent draft. These are going to be the changes from what the rules are now to these rules.
Oh, yeah, that's a good point. Yeah, I just wanted to reinforce that from what I just said. So one of the things I asked our team to do for this presentation was to compare and contrast what the regulations are currently. In other words, what they've been since 1999 with what the draft rule for public comment is. Because as I read some of the blog posts and other comment that I've been getting, I just wanted to make sure everyone was clear about what the current rules say and then contrast that with what the draft rules for public comment are. Because I think there's some impression with folks that the draft rules for public comment went backwards in some areas from where they were with the current regulations. And for example, in drugs and testing and so forth, except for GPS, that's not the case. So this is the contrast from where we are today, because I just want to make sure we reinforce that.
So the first section of the rules is always the definitions that apply directly to that article. And so there are some changes in the definitions. You don't think I'm on? Okay.
She said, there you go.
All right. Is that better? Okay. So for the definitions, every article of rules starts with definitions that are specific to that article. And so we've defined a couple of things based on comments and based on changes in the rules. And I'll let Tom go through those.
Based off of some of the comment we received to clarify some of the current language, we defined the term addiction, and we worked with our Department of Behavioral Health Services to come up with this definition. It's actually a definition we have on our website, the BHS website, and it means a condition that results when a person ingests a substance that becomes compulsive and interferes with ordinary life responsibilities such as work, relationships, or health. Breach, we used a complete breach, a frank breach, or an incomplete breach as defining breach as a whole. And then we defined full breach, meaning that the time the birth, the buttocks of a fetus is pointing downward with both legs folded at the hips to include complete and frank breach. It's a little different than the current draft that is on our website right now. We did define complete, frank, and incomplete separately. As you can notice here, full includes frank. Consultation, we also expanded that definition to include a certified nurse midwife rather than just the physicians.
Yeah.
Okay. Under the consultation, when it talks about physician, I'm wondering if we can exclude the disclaimer that it has to be with an OB practice, because sometimes we consult about newborns, and that wouldn't be with a physician with an OB practice. Sometimes we're consulting about a heart thing. We need a cardiologist. So I'm just wondering if that little...
Who has an obstetric practice at the end.
So there's other physicians we consult with, and so I'm just wondering if that term that has an OB practice can be taken out or defined more for specialties or newborns, pediatric, something along those lines.
It's
later in the rule, that's in the rules.
It has to do with consultation as we use physician, yeah.
Are you seeing what I'm talking about?
Yes.
OB practice?
Yeah, OB practice at the end.
Because we consult with a bunch of different doctors, not just for newborns.
Right.
It would be
Right.
a pediatrician.
Right.
You necessarily need to consult with a newborn until you have a newborn, right?
Right, but sometimes we need to consult for
Yes.
our baby.
Well,
Yeah.
And we wouldn't be
So-
consulting with an OB.
Then do you need to define better what the consultation is for? I don't know why the light's on.
Test.
So the consultation request should state why, and then that would make it apparent as to what the reason is. And you can do that in your data reporting form. If you have to refer out, you have to communicate to the department why you referred, right? And then the question of what is the referral. So obviously, how else would you have a heart referral unless you had gotten an ultrasound? Without every ultrasound that's read is read by an obstetrician or a maternal fetal medicine physician. So in the fact that you got an ultrasound, you have that referral. It would be a subsequent
You know what?
referral.
It defines consultation on page 2. And at the end of that definition, it says regarding the care of a pregnant woman or the woman's child. So I do consult with neonatologists. I do consult with physicians other than an obstetrical practice.
Again, the question is always asked in the consultation. So that would, for example, you can get very specific on who you're going to consult, but I think you, and you probably
We
need to
define
be very
physician
specific on who you're going to consult.
In that? As
So you don't want to
obstetric
consult
practice.
a physician inappropriate for one
So that's
question
narrow.
than another, and if you open that up to have no specificity, that may lead, not you, but another reader to perform the wrong act inadvertently.
I just want the ability to go to somebody besides an OB, like a pediatrician, when I have a newborn with a little bit of jaundice and I want to consult. I want that ability. And so it's defining that I have to do a physician that has an OB
Strike out.
practice.
Okay.
I want a physician with something more than just an OB practice.
Okay, we can
Does
see
that
where
make
it's
sense?
we can see where it's used
perfect.
throughout and tweak it accordingly if need be.
Yeah. Okay, I agree with that. Okay.
Do we see one or no? Okay. No, fine. We also define serious mental illness, which means a condition of persons who are 18 years of age or older, and
It's a statutory definition.
it's a statutory definition.
This goes to. He's addicted to his iPhone. I'm just kidding. This is one of the things we've been talking about over the last few weeks, and we decided to go back to the statutory definition. Dr. Northrup, this is kind of what we had talked about: is what is the real definition of substance abuse, addiction, serious mental illness. So we just tied it back to what we use in the behavioral health system. So I think that's good.
This was taken from the BHS as well, yeah. Both these definitions for SMI and substance abuse were taken from our behavioral health web pages, so they're as up to date as possible. And for substance abuse means the continued use of alcohol or other drugs in spite of negative consequences.
Back to the consultant. I have a question. So in your explanation, that's inferring that you then continue taking care of the neonate. Does that imply that you are not providing the infant with the pediatrician or a doctor of its own at the appropriate time?
Well, no,
Be-
but
Because that's important.
right. But I think her. We're gonna buy like 10 mics
Pop my-
with the marijuana money. One of the things, it goes to what I think you're talking about, which is that we want to make sure that there's a broad spectrum, but the way we've got this defined right now, it limits the definition of consultation to obstetric for the purposes of the regulations inside the Act. And I'd like it to.
No, you don't. I mean, your consultation is based on the patient, and until you have the baby delivered, that baby then, you're not, correct me, but I'm assuming you're not implying that you then become the provider for the newborn.
We take care of the babies.
Of course you do.
Now,
immediately.
I'm going to explain a scenario for you. I had a home birth. The baby was born. I did the 1-day postpartum. It was over the weekend, so they did not had not had a chance to see the pediatrician. You know, the baby hadn't pooped. It had been over 24 hours. That's a concern, and I'm going to call a physician, and I'm going to run it by a physician. And I consulted with the physician, and I was told the baby should present to the emergency room, and that was the next step. So,
But
you know,
that's transfer of care of that patient to its pediatrician, correct?
No, it wasn't. It was,
Then you're practicing out of scope of practice. You're not pediatricians or lay pediatricians.
No,
So on page 24 of the rule rewrite, there's a whole list of consultations of the newborn, which means the baby.
Right.
And if I'm going to consult on a newborn, I don't want to talk to an OB. This is the list of the baby stuff that we take care of, that I want to consult with somebody that's not an OB.
Then I think in the rules, there needs to be some language that states when the transfer of care to a pediatrician needs to occur.
It's the consult, yeah.
There's two kinds of consults.
Can I just make one little statement? Midwifery, including certified professional midwives and certified nurse midwives in our programs and in our training, we include mother's pregnancy, intrapartum care, birth, postpartum care, and care of the newborn. We are trained in that. So that's part of midwifery model.
I'm familiar with midwifery model, and the pediatrician sees the baby relatively quick. So I guess I'm just saying, is that really a consultation need, or is it I need
Well-
you to see your pediatrician sooner?
Here's the thing, if you look at page 24, we're holding our midwives accountable.
I'm not saying you should.
Well, we're holding our midwives accountable for that period of care after the baby's born,
Why don't
and for the weight of,
pediatrician?
Because of definition,
if the definition applies to the whole set of rules. Yeah, that's why I say, what we need to do is to make sure that we're not using a one-size-fits-all definition, but that we're throughout the rule, right, we're tying it in to the appropriate level. In other words, so that when you have a newborn, that the consultation is not with an OB, the consultation would be with a pediatrician. We're holding you accountable in B on page 24 for that.
Yes.
So it's only appropriate that, right, so we
Thank
can,
you, Director
we can
Hubble. You
modulate
understand
it. It's
completely.
like a high, we're going to modulate it and make it appropriate for the right places, because right now it's one size fits all.
It would be phenomenal if we get past the adversary here. Truly, no. I'm not thinking of the practice of you, Wendy, or the practice of Mary. I'm thinking of anybody who may misinterpret the rules, and they may misinterpret what the intent was. And that's what you should be doing as a body advisory, what we should ask for in the rules. So please don't assume that that's my intent. My intent is just not to let there be mistakes made, and there be a provider, unfortunately, that maybe is not going to say, well, here's the rules, but I'm going to find the provider who gives me the answer I want rather than the appropriate person. That's all I'm looking for.
And in chapter 13 and 14 and 17, in definition on page 4, physician, allopathic, osteopathic, and naturopathic. So, and with that inclusion of obstetric, but the thing is, yeah, that's what we're asking. That's exactly what we're asking for. Yes.
We got it.
Got it.
Let's press ahead, because we got a lot of stuff to do.
Okay, and back to the application for initial licensure. We haven't talked about this since one of the second or third meeting. Defines an application requirements. You have to be 21 years of age or older. The current rules, I believe, say 18. Current certification in adult and neonatal CPR.
Before we move on, I want to go back to definitions. Are we past definitions? Yes. Okay, because on page 5, definition, transfer of care, it says 43-47. We want to include certified nurse midwives. And I think you had mentioned that in your PowerPoint. It's coming up. But transfer of care means that that a midwife refers the care of a client to an emergency medical service provider, hospital physician, or certified nurse midwife, who then assumes responsibility for the direct care of the client.
And we can add it. That was not discussed. We discussed nurse midwife for consultation. We can revisit it here for transfer of care.
It makes sense. Okay.
Back to the application for initial licensure. Documentation of a high school diploma, GED, or a higher degree. Documentation of certification by NARM. And a passage rate of 80% or higher on the jurisprudence test. Any questions on that?
I have a question about... We'll go back to definitions again. Then I noticed that we don't have certified nurse midwife defined. So maybe that should be added on. Physician is defined. We talk about certified nurse midwives throughout the document, but we do not have a definition.
Okay, we can reference that. There's a $25 application fee, a $100 jurisprudence testing fee, and a $25 licensing fee. The initial license shall be issued within 5 days after receiving all the documentation and fees. Denial of application if the applicant does not score 80% or higher within 180 calendar days after notification of their eligibility to take the exam, or if submit all documentation fees within 120 calendar days after they are notified that they passed the test.
I apologize, Tom, but I missed under application for initial licensure, where it says current certification in adult and neonatal CPR. They no longer offer certification. It's certificate of completion. That's the newest standard in the CPR. And we were also wondering if it could be something other than, who does the CPR? No, the American Heart Association, but any other entities that also provide certification of completion. I believe that's the correct terminology. You might want to reference the current standards in neonatal resuscitation and CPR, because I don't believe they give certification any longer.
Okay. Thank you. The renewal is done every 2 years. It must be submitted between 30 and 60 calendar days before the expiration date. And the applicant must show NARM certification or current department certification with no lapse in licensing, as well as the CPR certification, because they won't have that through the NARM.
Certificate of completion.
There you go. Or completion. How about just training?
Yeah.
We'd have to define that.
The question on the submitted between 30 to 60 days, that is before our expiration date, correct?
Correct.
So if my license expires April 30th, I need to have my renewal submitted by March 30th.
Correct.
Right? Okay, just making sure.
And it's 2 years.
And that's standard for all of our licensees. So healthcare facilities all have to comply by that same rule.
Yeah, and I believe that's also, it's in statute as well. This person shall file an application for renewal at least 30 days, no more than 60 days before expiration. Administration must provide written requests to be added or removed from the website. Must notify the department within 5 days after a client dies while under the midwife's care. A stillborn child has been delivered by the midwife, or a newborn delivered by the midwife has died within the first 6 weeks after birth. Provide a summary of circumstances leading up to the event and actions taken by the midwife in response to the event.
I love watching you jump. It's fun. A question for you there. Are we also going to include, say that the midwife had to transfer mama out to us at the hospital, and then we are the ones who get the dubious duty of birthing the stillborn baby? Is there a way that the baby is now away from the midwife's care, now with us in the hospital? Is there a way that we can track that as part of follow-up? We've got that, yeah? Just clarifying.
In the new birth record, it
Just
has
as long as
planned home or planned hospital.
Yeah, okay, so that, and I know in the birth certificate it's supposed to.
So you're
say-
asking how would we mandate the requirement for the nurse midwife or the
For the
licensed midwife to take responsibility for that report?
Not responsibility, just numbered for it. So as we're trying to put together our real stats for the future, we can see that baby came to us, so that when I have to do that birth, or when the physicians covering with me have to do the birth of a stillborn, that it's on there. Okay,
Yeah,
got
if
it.
you
It
turn
would
to
be
page
part of the reporting.
26 in the bottom, whether the client required transfer of care, and if applicable, we list a handful of things that are required to be submitted to us. Must maintain current certification and a
This is part of the administration.
certificate of completion. NARM certification, except for those that were grandfathered in. Their license cannot lapse. continuing education requirements for the previous 3 years, and must be able to provide a copy of the documentation to the department within 2 working days after it is requested.
Is there any room for demonstrating actual, I know that or at least that's what Wendy's communicated, that you have to demonstrate physical competency. So all of the physician providers have to demonstrate competency. So what physical competency is demonstrated by the licensed midwife? So there's an exam, and then there's NARM certification, but it doesn't spell out specifically what and who signs off on that particular practitioner.
That's what we're adopting as the CPM process is NARM, the national organization, does all of that. And there is a clinical aspect that you are in front of a qualified examiner who takes you through scenarios. You have to work on models. You have to demonstrate your clinical skills in front of them, and then they pass or fail you.
Can that be well, I guess you wouldn't be certified if you weren't.
Right, it's all done on the national level.
Can you break it
It's-
down even more specific? So you can be medical knowledge approved, but not clinical, and vice versa. So is there an opportunity to have that information?
It's on the website
Yeah.
of NARM, NARM.org.
But
So on the website, I could go and look you up, and I could see that you passed both the medical knowledge portion or the
If I didn't pass all sections, I would not be a CPM. And you would not be certified. You would not get your license
And you
if you didn't
also-
pass all sections.
you also have to pass an apprenticeship. So you have a preceptor who's designated to oversee your competency. So you're taught by the preceptor, and the preceptor also does skills check-offs and oversees you and helps you manage the delivery. So not only do you have to complete the clinical side, and then you would prepare with all of your documentation, present it to NARM, and then you would take the practical examination, and then you pass that, then you take the written.
For continuing education, obtain 20 CEUs during the licensing term that improve the ability to provide services within the scope of practice, recognize and respond to situations outside the scope of practice, and provide guidance to other services a client may need. That's pretty standard what we currently have, correct?
Correct.
We expanded the CEU approval to include American Nurses Associations, American College of Obstetrics and Gynecologists, MANA, American Medical Association, American College of Nurse Midwives, MEAC, or another health professional organization. That is on 9.
And is it American Congress now?
Well, it's both. Oh, okay.
So this is our opportunity to add anything on so it's the bottom of page 9. Is there anything, any other CEU approvals that you covered? I know any other health organization is pretty expansive, but I just thought if there were something specific that we could add right here, this would be the place to do it.
Something that's missing in the medical profession on CEUs that I'd like to see at least put in here is that the CEUs pertain to obstetrics. I, as a physician, can get CEUs and get my license, and I can be taking something on tropical medicine. So I'd like to see the CEUs specifically referenced to obstetrical care or newborn care.
How about midwifery?
Well, that's what it says.
Yeah, okay. It says that. Okay.
It does?
Yeah.
Oh, okay, it does say, okay.
Yeah, so if we ask for the list of CEUs, we will compare all of the CEUs, Dr. Northup, to see if they fall within one of these 3 categories. And if they're not, then we wouldn't consider them to be appropriate continuing education.
A real simple one, name change, submit documentation supporting the name change for the license. Duplicate license is a $10 non-refundable fee, and the name change will not affect the expiration date of the license. All All right, responsibilities of the midwife and the scope of practice.
These are some overall, this slide shows some overall broad changes that affect this entire section. So since the draft rules were posted, we added back in the exact same language for medication, or actually that's in that current draft.
Current draft.
So there are no changes in the medication sections from what the midwives can currently do. That language is exactly the same except for one typo was fixed.
Are you done with that? So I know on the medication thing has been a big issue, and what this draft reflects is exactly the status quo regarding medications as it is today. We've looked in detail into the statutory authority, what the authorities would need to be around additional prescription and administration authorities, and for us to go beyond what you're looking at would require statutory modifications. So that would exceed our statutory authority. So if the advisory committee that is formed, let's say we adopt these rules and we have an advisory committee, if the advisory committee urges the department to explore expanding medications, that would be the process that I would envision that moving in terms of, getting the department to advocate for statutory changes to expand what you see in here with meds. But I just wanted to be really clear that what's in this draft final rule for public comment is exactly the language, and I instructed you guys to don't change one word because I want to be able to say
Except dose and does.
That's one typographical error, but otherwise it's exactly the same because I wanted everyone to understand that.
And since we've discovered this issue in this process, we're hoping again that the department will help us with the future moving forward with statute, and opening statute, and eventually when this committee is no longer under open meeting law, that we'd be able to have a meeting, set up a time with you, Director Humble, and again strategized on how best to move forward.
Okay, so moving forward, we will modify to make all testing a required consult. They will not be a prohibited practice. It will require additional informed consent if the client refuses after the consult, but it would not become prohibited.
I have kind of a unique situation on this committee. And Director Humble, you weren't present at the first meeting when I kind of defined my position. I'm a licensed midwife, and I was licensed in 2006, but I've had 10 babies, and 9 of them were born at home and 1 in a birthing center. So I kind of have, I'm here representing midwives, but I am also a home birth mama. And I may be almost 47, but I still may have another baby. And I have never, ever had the blood sugar test. I have never been tested for GBS by any midwives. When I started having babies in 1988, when I first became pregnant at 21, there was no GBS testing. And when GBS testing came around, I was like, no. And I also want to help you understand, in 1988, I had books. I had, spiritual midwifery. I mean, really, I read What to Expect When You're Expecting and used that as a guide. But I had a wonderful midwife who guided me through the process and offered me these tests, and I made that decision to decline. And what you have now, though, in this generation, you have a cultural shift. You have young women that have information abounding at their fingertips. They want to know what diatomaceous earth is. They don't even have to know how to spell it, because as soon as they put it into Google, as they kind of get the letters in there somewhat correct, it comes up and gives them everything they need to know. So we're dealing with these women that are powerful and intelligent, and they're taking birth back. They're taking birth back. And when we look at the model that's been presented here, I'd like to just read a couple of things that one physician shared. Many physicians do support home birth midwives, and they are furious that their professional organization would not only try to dictate what women should do, but also how they should practice. In an open letter castigating ACOG and AMA, Canadian obstetrician Andrew Kostaska, MD, urged the American obstetric establishment to join the 21st century. Informed choice is the gold standard in decision making, and it trumps even the largest, cleanest, randomized controlled trial, he wrote. Science supports home birth as a reasonably safe option. Even if it didn't, it would still be a woman's choice. As scientific evidence supporting its safety mounts, however, ACOG and AMA will be forced to accede or get left behind. So I have, in my own personal, reading HB 2247, on the second page, lines 3, 4, and 5, within 30 days after the advisory committee meeting, the advisory committee shall submit to the director its recommendations concerning proposed rules relating to a change in the scope of practice. Well, I have my recommendations all right here. And I also have support from Human Rights in Childbirth, which I emailed Kara Christ that letter. I have also the support from improvingbirth.org and other recommendations with evidence-based practice. And I really think that when we move forward, we need to look at how all of a sudden in the 11th hour, GBS was thrown into this situation as prohibited practice. And that is a legitimate complaint for us to shout out to the world. We need help because this is ridiculous. 30% of women that test positive have to birth in the hospital. Now, with that being said, that's also 30%, of people having to pay the hospital. And I think there's money and there's power behind some of that. And I just want to really say that, and I understand you want to move it to consult, but a woman, first and foremost, should be informed, and she should have the right to refuse anything. And in my submission to you, I have included right to refusals. I have included everything that I could find on patient rights from ACOG, AMA, the WHO definition of patient rights. I also found something from the American Hospital Association. And so I just want to share that I have that for you, and I just wanted to make that clear.
So I just wanted to get some feedback from the full committee about what I would like to propose as an alternative to the language that's in the draft rules for public comment. And that would be to move the testing from the prohibited practice. In other words, if they decline on a prohibited, it would be a prohibited practice in the current draft. Move that to the physician/nurse midwife consultation. And in that case, let's run through a scenario. So you have a patient who wants to do a home birth. There's some of the tests they don't want to do. Let's say it's GBS and HIV. The midwife would do a consultation with either a physician or a certified nurse midwife around those tests that she would like to decline. And then after that conversation, and it could be, we changed the rules so it wouldn't have to be in writing, but you would have to document it if it was over the phone. If our licensed midwife at that point believes that the risk is manageable and that she would like to continue services, that can happen, but there would be an informed consent that would be specific for each one of the tests. So for example, instead of the blanket informed consent like we already have in the rule, there would be one around HIV. So there would be an informed consent. She's declining the test for HIV. There would be an informed consent that by declining the HIV test, I understand the following. And then in that way, there'd be an informed consent. It would be moved to the consultation. It would not be prohibited practice. And I was thinking maybe we could use that as an alternative.
But why consult? Why consult? I mean, literally, why consult? I propose that this advisory committee that comes into play drafts those informed consents that the state provides. I definitely don't think we need a consultation for every test that's refused. Another thing, if this goes into implementation, I am requesting that it gets pushed back to July 1st, 2014. I think when we look at increasing our scope of practice and when we look at initiating this whole, calling the hospital, we've got a year to come up with a plan. I think we need a year. We definitely need a year to formulate these informed consents, to begin incorporating this into our practice. These midwives out here have people due July 1st. You know, and I think that if we look right now with prohibited practice, a GBS positive mother, and now they have to set up consultations, they have to, if it even moves to consultation. So I think that I, on behalf of the midwives and the mothers, would really appreciate July 1st, 2014 in any implementation.
May I just ask currently, and I'm not even sure that you test for it, but currently on a positive group beta strep, what is the normal outcome? What do you do? Again, what do you do? I'm asking Mary.
Well, you can't lump me in with all the rest of the midwives because I work with a physician. So when you're looking at how we do things at the birth center, it's very different. If I was at home, if I was a home birth client, I would present them the information. I would ask them to decide. They would then decide if they tested. Then if the test came back positive, I would then ask them what they would like to do. Then we would go over the options. And one of the options that we use quite a bit is we refer to a naturopathic physician that does have an obstetrical practice. And that naturopathic physician would meet with our client, would review her history, and then offer a course of treatment. One of the course of treatments that one naturopath offers is she would prescribe 2 antibiotics, 1 week on, 1 week off. 1 week on, 1 week off. And then when she goes into labor, she would then start another antibiotic. Now, one other naturopathic physician prefers the penicillin injection. It's quite a lot of penicillin, but it's supposed to cover and kill the GBS for 30 days.
So regardless, if you had a group beta strep positive mom, the infant would be sent immediately or relatively immediately to a pediatrician or some type of practitioner that cares for infants, and they would receive antibiotics.
No, the mother takes the antibiotics the last 4 weeks of pregnancy. We test usually 35, 36 weeks, right? We would have a result. Once we get the result, then we would help her if she wanted the antibiotics. First and foremost, she doesn't have to do antibiotics if she doesn't want to. So we would go over all the risk benefits and alternatives, and then she would make her decision. And if she felt comfortable going to a naturopath and getting antibiotics, then we would help her with that. And then when she got the prescription, she would start the antibiotics.
Do you recognize that there's no randomized control study on IN penicillin versus IV penicillin and the actual amount of GBS that's available to the fetus at the time of birth? And why would you be a proponent of that?
I'm going to go back to what Dr. Kostoska, MD, said, that informed choice
I'm an
is
MD
the
sitting up
gold
here. My
standard
opinion means
in
nothing,
decision.
so I don't know why we're listening to his opinion.
Well, he gets it.
Here, I want to. So I'm going to ask Allison and Julie to weigh in on the concept of things like HIV, the other RH, all that, moving that to the physician consultation and then having some informed consent. If you don't want to take the test, if the person doesn't want to take the test, and then the midwife could continue to provide services. So is that something that you think is reasonable?
I think it's totally reasonable to have a form that I would sign. And what I struggle with is if the midwife has to consult every time.
Every time they decline a test.
Right. So I have no idea how many times people can decline or whatnot, but are we going to have midwives having to call and get the same information constantly from their consulting physician or CNM? That would be my concern. Like, okay, what are we learning here? What's the point of the consultation for them? Is my question. Can you guys have something on your website, some information, the same information maybe that you would put in the informed consent or not, or do you know what I mean? Like I just don't see for them. I don't even want to throw out numbers because I have no idea. But are they going to be making multiple phone calls about the same exact thing with no change? Do you know what I mean?
Well, my thought is that let's just take the HIV test as an example. That the life circumstances for the patients, the number of years that have gone by since their last HIV test, or if they've ever had one. Those things could all be different from patient to patient. And then what I'm thinking is that there would be a consultation to take into consideration the different circumstances for each patient.
But wouldn't a midwife just know that? Right?
Well,
I mean,
what?
hey, it's been like
Well, I
20
know,
years and you've been
that's
with a
what I
few
wanted
people.
to know. That's what I want to know from you all. I'm trying to strike a middle way here that allows
No.
us to continue the practice, but try to, in a way, manage potential risks where there are potential interventions, so that at least there's an opportunity
And
for that to build that connection. Because that's the other thing, as I've talked about this a lot in a lot of these meetings, is one of the things I'm trying to do with this entire rule package is to try to knit together the network. In other words, to knit together, to better build connections between physicians, EMS, midwives, consumers, the state health department, so that there's better connections. And it seems to me that when there's a declined test, that's an opportunity for a consultation. Like a lot of these, I mean, there's a lot of consultations in here for different kinds of conditions. And it seems to me that there would be well,
I totally appreciate that. I do. I get what you're saying, but what I hear from midwives here and the midwives that I talk to all the time is that they already do that. Like, they already reach out and do consultations for things that that's beyond what they can understand, or beyond their practice. But I don't think it's beyond their practice to understand what it means if somebody refuses a test. Like, I don't know. It just seems some of these things seem a little bit common knowledge to me. That
I just want to say that if I have a client and I'm doing her medical health history, and she just got pregnant with this guy, but she's had multiple partners, and we talk about, am I going to recommend gonorrhea and chlamydia? Absolutely. Absolutely. This is, when you look at, or HIV, sure, I am going to recommend these things. I'm going to give her the information. But, it's her right to decline it. It's her right. It's a human right to be able to decline it. I think that, too, when I discuss it with her and we build trust, maybe at 36 weeks again, I'll ask her, are you sure you don't want to test for, we can go ahead and run a urine. So,
and I think you're getting that that there's this right to refusal thing, which is the point of the informed consent, and I totally agree with that. I don't care. Sure. I can sign papers. I'm going to do my own research, and that's fine. That's totally fine. I just wonder about the consult thing. Does it really make sense? What are the midwives learning from if that's what it is? Or, are we really building bridges by having them have to call for the same exact thing every time? Or is then and I don't know how it works for them. I don't know if when you guys called, you have to pay a fee for your consulting physician, and now are they going to have to continue to pay all these fees to get the same information they already know?
I can't help but just sit here and ask myself the question, why? Why is there such opposition? Is it, one, you're really concerned about the fact that you're going to lose the patient because the consult's going to take the patient, or is it that you don't want to provide the patient with an opportunity? I get your issue about transfer of care on these points, but the consulting I don't understand. Why would you not want the patient to have the most information possible?
Because I think my midwife can give me that, and because I just don't think. I mean, the department has said it many times. Like, they don't want to have all of these rules and regulations in here for things, and I just feel like
we have rules and regulations.
I know, and I'm saying we shouldn't
nauseam,
have any rules and regulations. I'm not saying that.
I'm trying to understand.
I just want rules that make sense.
Yeah.
And, they have that right. So why shouldn't our clients have that right? If they're delivering in the hospital, we don't know if they're HIV positive or not. We can't treat them any differently. We can't initiate immediate medication for the baby or the protocol after.
So what percentage would you say decline an HIV test of your patients?
I would say probably 95%.
Really? Well, in my population, it's the exact opposite. And why? Because they understand by education, by me teaching them, that the vertical, time out, let me finish, ladies. The vertical transmission rate is significantly decreased if we provide them with medication. Now, I'm asking each one of you moms out there with those children in your arms, would you not want to provide that child with a decreased risk of contracting HIV? Yes or no?
We don't need to test every time because we're not forced to.
Well, I'm not suggesting that. And that's when you would refuse, right? You would refuse. I've had one before. I don't need another one. That doesn't say that you have to continue with this care. I'm looking at this going, I don't understand why
Maria,
you would not.
Let me help you. I want to try to help. I want to try to help you understand that a lot of times we have clients who have had babies already, maybe within the last 3 or 5 years, and a lot of them have had their babies in the hospital or they started out with the physician, and a lot of them have already had HIV testing done. So in that, and we get those records. Right. And so this next pregnancy, absolutely, they decline. And then, again, we offer them the information. And I have plenty of clients that, not a lot, but some that are new in the relationship and they haven't done it in a while. And they're like, yeah, I think I do want HIV. And I just tell them it's $20 more. And they're like, okay.
I get that. And you made that like, that's not the point. The point is, you have somebody who has HIV, is HIV positive, and we're upset with transfer of care or continuing.
No.
Well,
No, that's not what we're saying.
No.
It doesn't say that if they decline, you have to prohibit taking care of them if they decline these tests. It says if you have a positive culture, if you have positive HIV, if you have these entities and you know they're there, then you have to.
It actually says if we
Both. It has both in this draft.
It does. It's like back at the beginning of.
It says testing positive for HIV. I'm looking at it.
On page 13. On page 13, if you go and it says that. Is it on? Yeah, it says there's required tests that the client has to do, and then later it says that if the client doesn't do it, and then G
underlined on page 13.
It says if they don't meet the requirements of this article, which part of it is that we have to do all these testing, then you have to transfer care.
And for many of us, it's not that we would say no, it's that we want the ability to say no, that we need to be the ultimate decision makers. It's not the midwives making the decisions, it's not the doctors making the decisions, it's not the state making the decisions, it's the birthing mother making the decisions. And I think that's what's so important. Hang on 1 second. And one of the things that I respect so much about you, Director, is that you're an evidence-based kind of guy. So I'm curious, what evidence exists right now that midwives are currently doing anything less than full and informed consent for their clients? Because what you're seeing here is you're seeing a group of educated, really informed women, and having to have this mandatory consultation in order to maintain their relationship with the provider of their choice. It sends a few different messages. It sends the message, are you sure we're going to, second guess your decision and bring a doctor in? It's saying that, oh, by the way, you're going to have to pay for that service, which you may not want. It's saying that you're going to be subject to this one-size-fits-all kind of care. And so many women opt into the midwifery model of care because they don't want this one-size-fits-all where they have, defined protocols that happen with every patient. They want something more personal, and that's why they turn to their midwives. So I'm wondering if this could be made even better if women had the ability to opt out of the consult as well, because many of us don't want our personal information shared with physicians or CNMs.
Well, I'm curious what you think, even if you don't want to talk.
Well, I agree a lot. Actually, Julie said it very, very well, of just total client autonomy, that they are educated, they do understand, and also that you're questioning our ability of giving true informed consent, which I think you could pull any of our informed consents on any of the testing that we need to and are required to give, and you'll see very, very educated informed consents, very thorough. It's not like we are wanting our clients to opt out. It's not like we don't want to do tests, but they're very much informed
So
consumers.
when you take the NARM test, and what's in the NARM testing around, managing RH disease without having that RH test? I mean, what do they say about that? How do they say to manage that risk?
I don't know all of there's like 7 or 8 different NARM tests with different questions, so I don't know what questions they specifically. We are to address that. We are to study that whole subject matter, both with or without testing, both testing positive titers. I mean, all of it is addressed, and we are to have that knowledge. Specifically what test questions, I don't know.
Yeah, I think it all boils down to, and we all know research proves that the person giving the informed consent always can bias it. And it depends on the audience and the particular woman on which kind of bias she would like to hear. I think I recommend that maybe when we start this advisory committee, that maybe the advisory committee can come up with some really good standardized informed consent for midwifery model of care, and then bypass all this, the thought of having the home birth mamas have to go talk to a physician anytime that she wants to decline a recommended test. I think is crazy, absolutely crazy, and wastes a lot of time and demeans the woman. And so I'm thinking this informed consent thing would be really good in that advisory committee, where whoever gets to be on that committee, and I say gets to be, can really hammer out some really good standardized things. Do you agree with that, Dr. Northrup?
I'm okay with it going to committee, yes.
Director Humble, I'm asking for some clarification. The PowerPoint says that we'll modify all to make all testing a required consult. However, our current regulation only requires consult for refusal of RH test. What do you mean by all testing? It's unclear.
Just that all of those tests for RH, gonorrhea, HIV, GBS, all that would be in the consult.
And see, I think when we look at, I definitely want my clients to consult. And if they are GBS positive and they want the antibiotics, that's when they go in for that consultation, and that's when they receive those antibiotics. So there are definite appropriate times for our clients to actually physically see a physician and consult with them. But every single refusal of a test, us having to contact a physician, it just doesn't make sense.
So I'm trying to, I'm willing to talk about this a little bit more. So what I want to make sure that we have done at the end of this rule is that that all of our licensed midwives have all the information that they need to have that conversation around declined tests. And so I just need to make sure that and if there's consensus from the group, we're willing to. Now, having said that, I would like to go back for a second to the proposal about a July 1st of 14 implementation date for the whole thing. So do we have a consensus from the committee about instead of just the VBAC and the call to the ED being a July 1st of 14 start, if we would do everything on July 1st, 14?
Can we opt out of the CPM, going to CPM, and also the electronic quarterlies? Can we have those, except for those?
And
but immediately
probably
go
the
to CPM
advisory
state and
committee as
immediately
well.
In other
go
words,
to quarterlies
have the
and advisory
so
committee.
we would have the administrative parts of the rule become July 1st.
2014.
If it,
No,
it might-
the administrative would
That
be
goes
July 1st to
immediately.
13, and everything in 108. The scope of practice would be,
You're also losing then, right, that you can have the consult with the CNM, right? I think, so that would,
we'd have to talk about,
That'd be hard.
the definitions would be difficult for July 1st to 13, but I think we could segregate out the scope from the administrative, have the administrative go immediately, and then have the scope shift on July 1st to 14. I think that's...
What about the emergency measures, though, as well?
Yeah, and
Then that in
there's
scope?
yeah, and then there's emergency measures, and right now everybody is supposed to be under Friedman's curve. I think there's still things that we wouldn't want. I don't know that I.
Yeah, I mean-
let's do it now.
So
I don't know how to fix that problem, but
this is a really important thing. I want to get some more feedback on that.
I'm not completely convinced that we need to push it all to 14, especially the administrative stuff. But then, like we've talked about, there's some pretty important things that I would like to see changed immediately, like the emergency measures. Yeah.
I mean, what's appealing to me about a July 1st to 14 change for the scope is it gives the advisory committee an opportunity to meet for a year around the informed consent type of issues and those kinds of things so that we can have and adopt and maybe even refer in the rule to, like we do in practice bull, we'll figure something out where we can refer to the committee's work products inside the rules, but that we need that year to make that stuff happen. So, what's that?
I don't think it's a good idea. Sorry. I mean, I think there are some things, the things that we've talked about already. I don't know. I just think that you guys have made change. You're kind of, proposed to make some changes that I think need to happen now, and I'm just a little leery of saying let's push it all back because
You want my selfish opinion? I'm pregnant and I'm due in early January. It is kind of a sad irony that I will be outside of these dates.
Yeah. I don't know.
I don't think we should push it back. I think that I think especially if there's some clarification about the right to refuse and consults. And yes, we have to hash out all the details, but I don't think we should push it back.
So what about the women that are due July 1st? What about the mothers that are due in July? That's my concern.
What's your
Well, I mean, depending on how things move forward, if they've refused testing, are you going to have to go back to all the women that are coming up and their due dates and, start consulting? I just think
it sounds like we're moving in a good direction. I think we just need to keep moving in a good direction.
And that's something that we could set as a policy, as a substantive policy or guidance document, that it would take effect for pregnancies starting after July 1st. I mean, there are things that we can do in licensing.
And we're overhauling all of our regulations for our thousands of licensed facilities, hospitals, assisted living, skilled nursing. And one of the things that we're going to be doing in that rule package is we'll file the rules probably June 26th or 27th, and then they'll have an October 1st of 13 implementation date to give the facilities an opportunity to write the policies and procedures and so forth that we're going to be holding them accountable to. And we could do that phased approach where we have the administrative pieces take effect October 1st, for example, and then have the scope be later. We could have the scope of practice be October 1st instead of July 1st to give a 3-month period. VBACs would still be July 1st to 14.
3-month period to do what? To do maybe what Janice said? You want a 3-month period to do what? To maybe do what Janice
Well, the advisory committee could come into, could be born right away,
and
right?
create
And if they were working really hard, they'd have to work really hard before October 1st to come up with the informed consent piece around the decline test. And that would give 3 months for them to develop that guidance document, or it could be 6 months. They could have 6 months to do that, and it could be like a January 1st to 14 for the scope, put the administrative and the advisory committee as an immediate implementation. And then by the time the scope changed on January 1st, the advisory committee would have molded the informed consent around declined tests.
I think whether the done date is 3 months, 6 months, or a year out, it doesn't matter. People work to a deadline, so it could be a week. And we would get them done. You know what I mean? Like, I'm willing to work day and night, so the deadline doesn't really matter. It could be a week. So July 7th?
All right, so let me... Battery's dead. Those batteries. So let me propose then, let's start with the out dates first. So the VBAC and the call, that requirement to call the birthing hospital would be July 1st of 14. The scope of practice shift would be October 1st of 13. And the administrative pieces of the regulations would be July 1st of 13. And the gap between July 1st and September 30th would be the responsibility of the advisory committee to come up with the granularity around the informed consent piece on the declined tests. That would be their first task.
So are you then saying that we're not going to have to consult? That if the informed consent would...
That would be the job of the advisory committee to define... Right. It would be moved out of the consult for the tests, except maybe for RH. Or all of them, all of them are, and then have the advisory committee develop the informed consent.
What the rules going to look like now? Like, when they're posted? Tom's laughing over here.
He can do it, I know.
Tom's laughing.
He's like Scotty on Star Trek,
actually...
I can't do it, Captain. And he always does.
When these get posted, what is it going to look like? Am I going to cry? Or am I going to, is it going to scare me a little bit? Or, I don't know what it's going to look like, this whole,
Well, there would be phases of implementation. So the administrative pieces would be effective immediately, including the advisory committee.
So are you just going to write in the rules that some informed consent documents are going to be drafted? Or,
well, there's a way of writing it, but...
But the idea is that you will be able to refuse with informed consent?
Yes.
Period.
Yes.
No consultation?
Well...
I'm just asking.
I'm not going to presume to be the full committee, right? Because this is going to be the advisory committee is going to come up with the process for informed consent.
Okay, so
that informed consent could include a consultation or not.
Okay, fine. Okay. But in the rules, it will just say that
it'll be broad and flexible.
An informed consent document must be signed.
Yes.
Something like that. I know.
Developed by the committee, because the committee will be inside the rules, which will make it official. The committee was formed immediately, right off the bat, so it becomes part of the rules. So then it takes on the authority that we give them inside the rules.
Fantastic.
And that would define the nature of that informed consent, which could or may not include a physician consultation. But I don't want to prejudge the committee. I want them to come up with what they think is reasonable.
Okay, wait, I have another question. Okay, so say the client decides to test, and then she gets positive on something. What are we doing with that? Leaving it how it is? Leaving it how it is in the current rules? Leaving it how it is in the draft? I don't know. No, she gets it, and then she tests positive for one of the things.
During the 3-month window, which rules do you comply with? That's what you're asking.
That, and after the 3-month window, what's happening? That's my question.
The question is standard of care. And so if standard of care in midwifery means you don't need to treat HIV, you don't need to treat GBS, you don't need to and your patients are okay with that?
Well, I don't think that we are, but I don't want to speak for everybody. But I like that it's the standard of care for midwifery standard of care. That's kind of nice.
There's going to be a huge dichotomy, and if you're okay with that, Will Humble, I'm okay with it.
So this is different from the testing, okay? What we're talking about now is not somebody who's declined the test, but somebody who takes the test, is positive for HIV, and says, I still want to have this at home knowing I'm not going to get antiretroviral therapy for my baby.
Or the patient.
Or the patient. So,
If I had a client who tested positive for HIV, I would probably transfer care. I mean, that would be my personal protocol as a midwife. I would.
so that's where it's at in the rules now.
Yeah, I guess that's what I mean. Like, are we sticking to, and I don't know, I can't remember. Is it different in the proposed than what the current rule?
Well, GBS is its own separate
besides
animal.
that.
Besides, set aside GBS for a second. But I would propose leaving the others as it is today, and GBS would be something that could be, you could still be positive and not transfer care.
So including RH factor as well?
Well, what's it say in there now?
Prohibited.
It's prohibited in the current rules.
Prohibited for refusal.
Yeah, we were
Refusal.
with perinatologists sometimes. So sometimes when we have an issue come up, we will refer them to a perinatologist. And so they're seeing us and a perinatologist. So we follow the pregnancy. And depending on what treatment or testing they have done, towards the end of pregnancy, we come to a decision, where is the best place for them to have the baby. So, like example, we had an ultrasound come back. There was something on the ultrasound. We sent her off to this person, that person. They consulted with a perinatologist. They consulted with a pediatric cardiologist, surgeon, and it ended up coming back that she was safe, that it was fine for her to birth out of hospital. So we do consult, and sometimes we do dual care.
Prohibited.
Okay, so
Right? It used to be that if you tested positive for HIV, syphilis, gonorrhea, or hepatitis, you just had to consult. But now it has changed to transfer.
Prohibited practice.
Yeah.
Okay.
In the posted version.
In your draft.
Right.
So go back.
So that would go back to how it was in the old rules.
But why was it changed in the first place? Is it because of the medications they need to take get delivered to them?
What she's
Why
reading.
was it changed in the first place?
I don't know.
I don't
Why
know.
was it
I'm
changed?
asking the question. Why was it changed in the first place?
We'll have to take a look at that. I'm trying to figure out what's current right now.
Oh, the current.
What's currently.
Hold on.
No, no,
We'll
no.
take this is important. Let's take a minute.
So hold on a minute.
There's different versions.
70 versions. Here.
Required testing positive for HIV.
Consultation.
The rest
It's
of
all
it was all
In prohibited.
in prohibited. I think syphilis and that was prohibited.
Some of them were prohibited in transfer of care, and some were in counsel.
Active.
So gonorrhea, for example, was
Active.
active.
Active syphilis. So all of those were prohibited, and HIV was a
Well,
consultation.
So if
refusal of RH was a consultation.
That's right. So active hep, gonorrhea
Until recovery.
was prohibited. Herpes.
And then RH disease with positive titers was prohibited, but the refusal was a required consultation.
Correct.
so to keep it, we talk.
Sorry.
Yeah. So if we were to go back to how the rules are today in terms of transferring, depending on the positive, right? You can live with that.
Could you read them so we know exactly what they say?
I'm talking about the current rules. Not the draft or not anything we wrote recently, but the 1999 rules.
It says you have to consult for HIV.
You do a consult for HIV, you do a consult refusal for RH blood work. That's it, right?
And then prohibited practice currently is heart disease, kidney disease, blood disease, which we moved to a consultation, RH disease with positive titers, active tuberculosis or active syphilis, active hepatitis or active gonorrhea until treated and recovered. We changed active hepatitis because we know that there's several times to just B and C, and then moved those. So they could still do hepatitis A, anything that's related to some kind of chronic hepatitis, that becomes a consultation.
I don't know, I think I'm confused.
So, again, there's two different things. There's testing, and then if you test positive.
Right.
And right now, all we're talking about is a test positive.
Right.
And so-
We've already sealed what we're going to do on testing.
Right. So I think, and perhaps an outcry from the audience can tell me, going back to the old rules of a testing positive, I think I'm comfortable with.
Okay.
Okay.
Although the one thing that I think most midwives have voiced is a second degree or greater laceration. We shouldn't have to consult for that.
That's not testing.
Oh, just for testing, okay.
Okay, so let me just wrap up the testing. So regarding the testing, this is what we're planning to do for the final. There will be a process to refuse testing that the woman can go through. Doesn't require consultation necessarily, but we won't know until the advisory committee meets and comes up with the procedures around informed consent and how that informed consent happens. And the committee will establish that protocol, and our rules will refer to that protocol, which would then become effective October 1st.
Director Humboldt, how does that happen? Once we formulate that, can you just add that to the rule then? Because, I mean,
Well, we can, there's a thing called a substantive policy statement that we could incorporate into, in other words, the rule can refer to a substantive policy statement that the committee develops.
okay. And so then that statement will go up?
Yes, it's
Okay.
called a substantive policy statement. We do it in EMS all the time. And since the rules will refer to it, it has force of law for the regular administrative law. For the tests that are positive, we would just keep it exactly as it is in the 1999 rules. Except for there's different kinds of hepatitis now.
Right.
Which in those days there was just non-A, non-B and stuff. Okay. Okay. That was an important slide, but I think we got through it.
I'm sorry, before you go on, could you flip back here? Okay, before July 1st of 2014, the state of Arizona is going to have to explain the inconsistency in licensing. The problem that I have is that the licensure department, Connie Belden shop, will not license a hospital under Title IX to perform, if they're licensed practice obstetrics, they have to be able to perform a C-section within 24 hours, 365. So you can have a normal delivery. In the case hospital in discussion would be Sage Memorial up in Ganado. They applied for a licensure to be an in-house birthing center, and it was refused because they couldn't do a C-section. Now the state of Arizona, who presumably treats all healthcare providers the same, is saying, okay, we can not only do low-risk deliveries outside a hospital, but we can do high-risk deliveries outside of a hospital. That's incongruent. And we're not going to get it done today, but you're telling hospitals, they can't do low-risk deliveries, but you're giving another group of healthcare providers high-risk deliveries outside of a hospital. That's inconsistent.
Maybe we should change the hospital policy.
It might be a CMS policy that is a federal, but we'll take a look at that. Thanks.
There's 2 hospitals in Arizona that are in-house birthing centers that don't do C-sections. One's in Palaca, the other's in White River. But that's it. The state won't do it. And this inconsistency is probably half the confusion that we have here. We're being held as healthcare providers across the board to a certain standard by the state of Arizona. And now we have a carve-out group. And I'm not, that's not negative or positive. It's a slippery slope, though. When the state of Arizona treats everybody the same except one small group, and it's so different, you got a problem.
I didn't know any of that.
We'll run back with Connie. We'll run back with Connie.
Okay.
Wait, I think you should,
If we have GBS positive, since that's not it, what are we going to do? Consult? We're going to, because I don't know, but it seems like there are treatment options for that. And I don't know.
maybe I should.
Well, so we looked at the evidence. So with GBS, we pulled up all of the reported GPS cases from our EPI group did that. And how many cases have we had in the last few years?
167 invasive neonatal infections.
So we've had 100, yeah. So the risk, we've established there's a risk out there, but we also ran it for home births, and there weren't, out of that group, there weren't any that we could identify as being home births. So
is that
because
they're already referring? And
we don't know.
Treated?
We don't know.
Right, and I asked most of my questions in that format because I'm assuming you don't know.
Yeah.
Not you personally, we just haven't been collecting that information. And that's the problem, is we have no information on what we're doing well or what we're doing not well.
So for GBS, if they test positive, it would be a consult.
Only 14% of your reports are available. When we started this process, we asked for that data. As a committee, we asked for the data, and the data was unavailable. We couldn't see the data. So it's not to suggest that what's being done currently isn't good. We just don't know because the data isn't housed appropriately, documented appropriately, put on a spreadsheet. And I don't know, but
This data is actually infectious disease epidemiology data that's required by law to be. So this one, and then we matched it. We found a match for every provider. So if it was delivered in a hospital now, it could have been transferred for other reasons and delivered by a physician, and that we wouldn't know, but every single one of them came up with
right, I understand, but there's babies that have been born at home, potentially, I don't know, maybe not, but there's babies at home that may have been treated with an injection or some other method. We just don't have.
We don't, right.
We don't
so
know.
all we really know is that there is, we have outcomes like that out there. So I want to try to do what we can to manage and try to mitigate some of those outcomes. And I think if we put that into a positive GBS test going into the consult part of the regs, then if you want to do the wash thing or the IV drugs, or there's different options that the midwife could consult with on the physician, with the physician or nurse
What
midwife.
I don't understand is, what would you consult about? Hey, Janice, I have a positive GBS mom. What am I consulting about? I don't understand what information I'm needing from her that A, I don't already have, or B, can't get. With the exception if they choose antibiotics, which they do, then of course we consult with a naturopath, a physician, somebody that can get them that antibiotics. But I can already, on my own, educate them about all the choices that are out there, the wash that you mentioned, all those other things, and then they can decide, oh, I want antibiotics. Okay, I'm not able to give that to you, so now I'm consulting because that is out of my scope, but it's an option. So just because I have a positive GBS doesn't mean I get Janice on the phone and say, hey, I have a positive GBS woman. What is she going to do for me? I haven't given choices to my mother that she is deciding what she wants to do. Does that make sense? I need the power to give them the choice, and then they have the power to make the choice, and then from there, a consult is maybe necessary or maybe not. Does that make sense? Did I explain it?
That's how we've been doing it.
Yeah, I just wonder, like, because they have been testing, midwives offer this test for a long time, and so if we don't have any numbers to say that we're having poor home birth outcomes because of GBS, then why regulate something they're already doing well, presumably?
Okay, so by October 1st, the committee will have come up with a procedure around how to do the informed consent on GBS. I'm going to start calling it Group B strep. And that, because that's going to be, that will be in the list of all the other informed consents around what the committee just does to come up with the, how to make that information digestible.
Because theoretically, it could say something like, in the informed consent, if, prescription treatment options are necessary, then you would need a consult, right? I mean,
right. I'm okay not having that as a consult.
The only thing that needs a consultation is so that the client can then go get medicine. Then it could be written in on the informed consent sheets like that.
Right.
So it's not a consult.
Say that again.
Well, and I think that that's one thing that the informed consent, going back to some of the comments earlier, while I think that, the midwives that are on the committee are very good, in some of the reports that we saw, it would be called naturopath for positive GBS client. Naturopath said no treatment needed, no antibiotics, no wash. So I think that they're, having a consistent form would be good, because I don't know that all of them share your same background. All right.
Help me. If they're usually going to see the naturopath at this point right now, then they're usually going for the antibiotics.
No, this was just a consult that was on there. Like, it was in the quarterly report, and it said consult, yes,
Oh, yes.
GBS positive. And this is, again, this is the naturopath. This isn't, but it was no treatment necessary, no, advised against antibiotics, wash, this, and this. So, and that was on several patients, and it was the same naturopath.
Okay.
So on the, based on feedback, we deleted the wording low risk and are now requiring midwives to provide services to a healthy woman. An expected outcome of pregnancy to be delivery of a healthy newborn and an intact placenta. We expanded the scope of practice to prior cesarean section and fetus in a full breech presentation, and we removed the multiple gestation out of the scope of practice.
There's been some comments about the decision to go with complete breech instead of frank.
And that's been changed. We fixed that. That's why it now says full breech.
Okay.
May I? I have just a statement that I submitted, and I don't know that it's going to be posted in time, but I think it's important that I at least have this say. In times when challenged with requests for change, it is incumbent on those in authority to determine if change is needed, and if so, what change is required. On March of 2012, the Arizona legislature passed HB 2247, an act relating to the licensing and regulation of midwifery. It required that before July 1, 2013, the Department of Health Services would consider adopting rules that reduced regulatory burden and streamlined the regulation process. It asked to revise midwifery scope of practice, given why an increase in the scope of practice is needed, that evidence demonstrated that current practitioners are competent to perform the proposed scope of practice, and to what extent the scope of practice may harm the public, including the extent to which an increase of scope of practice would restrict entry to the practice of midwifery. Consumer groups have identified a desire to be allowed to deliver their neonates where they deem appropriate. For the purpose of this committee, it is in the home setting. In this request, they have asked to remove the barriers of high-risk pregnancy as it pertains to prior cesarean section, and fetus in breech presenting position. The licensed midwife groups have identified that in giving care, they would like to have medications available to them in the event of postpartum hemorrhage that could not easily be controlled with fundal massage. Physicians, emergency transport, and hospital groups have expressed extreme concern and disapproval for the expansion of midwifery practice to include prior cesarean section and breech presentation. Sadly, when the standard of practice in 2002 changed, the health department did not remove breech from its rules to revise what commonly, even in midwifery practice, was no longer done in the home setting. To use this rationale that breech presentation is already allowed is an example of not using evidence to drive practice of care. For a small group relative to all women in reproductive age in Arizona, we have heard why there is a perceived need for change. There are also many women who find the rationale of delivering in an environment that could provide emergency care the best place for delivering, especially in high-risk conditions, such as prior cesarean section and breech presentation. The advisory committee has heard from the University of Arizona Public Health College, or Public Health, that the risk of neonatal death is at least threefold increased in a planned home birth compared to a planned hospital birth. To this point, I will continue to argue that this extent of harm to public is great enough to disallow increasing the scope of practice of licensed midwife in Arizona to include prior cesarean section and breech presentation. Justifying the data to assume that the literature review does not fit our state or population is wrong. On the contrary, we have limited data on how well Arizona licensed midwives have been doing with the normal risk population. The committee has heard anecdotal data, both bad and good. Finally, I argue that HB 2247, Section 1B2, the available evidence-based research that demonstrates that interested current practitioners are competent to perform the proposed scope of practice has in no way been demonstrated or determined. To allow prior cesarean section or breech in scope of practice assumes that the current Arizona providers have been trained and deemed competent to provide this practice, that the home environment has been tried with this pregnancy population, both of which are not true. Given that these two conditions are included in the new rules, would be to put the cart before the horse, more clearly defined as to have things in the wrong order, to have things confused or mixed up. The department needs to meet the letter of the law that has yet not been determined, and the current data is lacking, quite possibly, cannot be done. Much discussion has been had, many opinions have been heard, but at the end of the day, have we determined that change is needed and what change is required? I and the Arizona Medical Association and the American Congress of Obstetrician Gynecologists oppose including prior cesarean section or breech presentation in the scope of practice for licensed midwives in the home setting. We request better data collection, more transparency, and determining that current practitioners are competent to perform the proposed scope of practice.
Actually, there's been a huge amount of evidence and data submitted to show the increased scope of practice in both of those. And also, Director Humble sees that it needs a year of implementation. So we're waiting on those things, which I think is completely reasonable.
Just one thing I want to know. And just in looking forward, I know, Dr. Northup, you brought up making sure that the midwives have training, and that has been something that, of course, we've heard, and that's why I'm looking at our autumn-fall conference in November, focusing specifically on breech and VBAC as our, getting ready and attaining skills. And I, for one, would travel to gain more.
What struck me most when the doctor started speaking was the word authority, and I think from the consumer point of view, that's a really important word because the reason we're asking for this increased scope of practice is that we believe that we're the ultimate authority when it comes to our bodies and our babies and the decisions that we make. So I think this is welcome. I think that even in light of what might be a larger risk, it is still a low absolute risk, and in light of those things, we need to defer to the autonomy and the human rights of the woman. All right, thank you. I wonder one additional thing. Some of the data that we have about women seeking home births is that it's not even first time or typically even second time moms who are looking for a home birth. This isn't their first rodeo. I wonder if the director would entertain an amendment such that a woman who would be out of the scope of practice ordinarily for VBACs, who's had a successful in-hospital VBAC, would be allowed to birth at home.
This is our last meeting, right? And you had mentioned over the course of meetings that you want some form of consensus or some kind of, I mean, how do we move on that?
I wanted to get through the PowerPoint and then I'll ask for that.
All right, so for the informed consent, it's on the department-approved informed consent. It discusses the midwife's scope of practice, educational background, and credentials need to be discussed with the client. For VBAC and breach, the midwife's experience with these types of deliveries and the potential risks, adverse outcomes, and alternatives to an at-home delivery. So I don't think that these have changed much since we've started this process. Again, the required tests and potential risks, if declined, the need for written documentation of the client's decline, and again, that'll be on a department-approved informed consent that will be developed by the advisory committee. The use of a physician for consultation, and that we can include the certified nurse midwife or the use of a healthcare institution in an emergency, and then the need to transfer care in an emergency to a medical services provider, a hospital, or a physician, or a certified nurse midwife, as we just discussed. So the written consents must be in the department-approved format. They've been on our website for a while. There's the informed consent form, and then we will be creating with the advisory council declining tests informed consent, and that needs to be signed by the client and the midwife. Also, since the rules that are currently in place, the newest rules still have the establishing an emergency care plan. They have to identify the closest hospital with OB services. If it's a VBAC or breech delivery only, it has to be within 25 miles. They need to identify the emergency medical services provider, and again, that emergency care plan must be signed by the midwife and client, and a copy of it must be maintained in the client's file. All right, so these were just a couple of the things. We've already made changes to this just during this meeting, so this slide is no longer up to date. Refusal will be moved to a required consultation with a required signed informed consent. We will work on that moving forward, but these were some of the tests that were in the current draft. Currently, the draft has a refer for ultrasound, so the ultrasound is supposed to determine the presence of the placenta, or where the placenta is located in fetal abnormalities. The VBAC, we wanted the ultrasound to determine placenta location and risk for placenta previa and potentially placenta accreta. And then for the breaches at 36 to 37 weeks, confirm the fetal presentation and to get an estimated fetal weight for breech pregnancy.
There's a couple things about ultrasound if we could have just a little bit of conversation about. One is the placenta previa being corrected in the first trimester. Placenta previa usually is never corrected in the first trimester. Usually you get a later ultrasound to show and prove that previous. Did you change that already?
It should say, and I noticed that in this draft it didn't, persisting after the first trimester.
But usually they don't clear until the third, and usually we don't get another ultrasound until the third trimester. So I'm just
okay. We can put that in.
That wording is okay.
Okay. Yeah, we can take that into account.
And then I don't have the exact wording of the ultrasound stuff in front of me, but
we can change that in a second.
This is correct.
Oh, well, I just moved that we strike that. Refer for at least one ultrasound.
I totally disagree with you. So, I would definitely. I mean, if this is where I really will draw the line in the sand. You have to know whether you have a previa on a prior cesarean. You have to.
Oh, that's not for cesarean.
Okay.
No, I'm just talking in general. Yeah, in general, it's saying that all women have to have an ultrasound.
No, it says refer. So. But it says refer.
refer a client to for at least one ultrasound and recommend follow-up testing. So if that stays refer, then we just would write refer, but we have to refer them, and then they have the right to refuse that ultrasound?
A referral is like a suggestion. So I suggest you go get an ultrasound.
Okay.
Now, on the VBAC, it's different.
Right. And that's okay.
On your general obstetrical care, non-VBAC, non-breech, it might be better to say obtain an ultrasound on every pregnancy, because anybody can walk into an ultrasound shop and get an ultrasound. They don't need a doctor's order. They do that. I defy you to tell me how many people today deliver a baby without an ultrasound. They all want them. They want to know what it is. They
Actually, it's not true with the home birth population. Our home birth population do not
well,
want
I'm not
ultrasounds.
saying that they have to, but in this instance, yes, on a home birth, I would say that you need to pick these things up. We do it. I mean,
I understand you do it, and I understand that, that it could be a good thing, but again, going back to patient autonomy, if they don't want the ultrasound, they should have the choice to opt out of an ultrasound. So just like any other testing, I think that it should have a choice of having it or not.
Except on VBACs.
Except on VBACs, of course.
Right.
VBACs aside. Totally.
Also, if we don't encourage the mother to have at least one ultrasound, how do we know if we're not dealing with twins or triplets? How would you know that? By Leopold's, you can be off on that also, for sure. Just as you can be off on a breech. We all know that. You all know that. Every single one of you. So I would hope to not see in the future that twins are being born at home because it was a surprise. None of you are going to do that because you will know ahead of time whether or not you're dealing with multiples or not. And where the placenta location, where the placenta is really, really critical. You need to make sure that you're not dealing with a low-lying placenta or placenta previa. Y'all are good, you aren't that good, because you can't tell that just by feeling a woman's abdomen, right? We can't. So from the nurse midwife perspective, we would recommend that there is highly recommended to the mother at least one ultrasound to verify how many babies you have, where the placenta is, highly recommended. In fact, I would not accept if I had a home birth midwife come to me and the mother is refusing an ultrasound to verify how many babies you have and where their placenta is, I would not take that case because I would consider it way too risky.
But again, it comes down to patient autonomy. They have the right. So if we go through all of these risks and we talk about everything that they can find and they still ultimately, in the end, do not want to take the risk of an ultrasound, that is their option. It should be their option. And that's just what we're saying. That needs to be in there clearly. Absolutely. Which I think is great.
Except for VBACs.
I think I had 5, maybe 6 babies without an ultrasound.
Okay.
All right, so moving on, the responsibility of a midwife is to visit the client's home or place of birth to determine if the environment is appropriate for birth and if there's a communication available to the hospital and EMS provider from that location.
Just one note, can we strike home and have...
Yeah.
Yeah, we're going to change that to birthing location. We noticed that after we discussed this. Yeah. All right, so then during labor, the midwife is to notify the charge nurse of the hospital identified in the emergency action plan when the client begins labor and ends labor. However, they only need to report that the client is laboring. They don't have to give any client information to the hospital, just that this specific midwife has a patient laboring in the community and whether there's a high risk associated with it.
That's July 1st of 14.
And that's July 1st of 2014.
Is the committee working on doing, what are we doing between now and 2014?
We'll have to give all of our hospitals notification that this is occurring, and we'll be doing that through our licensing mechanisms as well as potentially the Arizona Perinatal Trust.
Yeah, what's going to happen is hospitals are going to have to develop policies on how to handle this. It's just a logistics thing.
Yeah, no, that's fine.
Yeah.
That's good. I just want to make sure it happens. So.
And can we just have on the record why Mr. Humboldt, you guys are requesting that this is done for normal births? I understand that it's that you just want to build more of a community, more of that the people in the labor and delivery units around the state know how many home births are happening in their area. Is that the rationale?
Well, and if hospitals need to make staffing decisions based on a laboring patient out in the community, they have that information so they don't send their scrub techs home.
And that's a point I made several meetings ago. Good Sam could care less whether they hear this or not, but you can't carve them out. It's for the smaller hospitals that have to make staffing decisions and may divert. They may say, no, we can't do, or we don't have a bed. We've closed our unit several times because we didn't have a bed or we didn't have staff or something like that. So that's the reason behind it. Well, just another comment, I can't help not making it. A lot of the tension over the last 8 months in here has been about patient autonomy. And it's always going to be a tension between what's best for the general public and what's best for the individual. If you go the complete route of patient autonomy, you don't need the state of Arizona. You don't need any rules. So at some point, there's got to be a balance between rules. What's not happening in Arizona, which does happen in successful midwifery programs, is communication between the two, between organized medicine, the hospitals, and the midwifery. A lot of what we've talked about is to drive that. This is one of the things, to drive that communication, make it happen until it becomes comfortable. We had this long discussion about consultation, mandatory and transfer of care. That whole discussion should go away if there's good communication between the midwifery community and the organized medicine. And that's what I think, if nothing else, if we can propose some rules that'll get that conversation going and make it keep going. I think you have to make it keep going because it's not going to do it on its own to start. So that's just a comment from the other side.
Thank you. All right, so for the scope of practice for VBAC and breach, the progress of labor has to be determined per Friedman's curve right now. The rules are structured so that if there's a change to future standards, they can be adopted. The progress must be tracked and reported on the midwife report, and if the patient does not meet progress criteria, must initiate a transport.
What if it says, instead of established by ACOG, just evidence-based practice? Or
Read what it said.
That's
changed.
paraphrasing what's in the actual rules. It doesn't.
It's page 18, Tom.
Oh, it's right here. Yeah. Let's see, page 18.
The progress of labor according to the management guidelines recommended by ACOG. So that is what it does say.
But I guess my question was if we could, I think it was submitted to you guys, but maybe it wasn't, and I need to. And Janice, correct me if I'm wrong, but CNM told me that she was just renewing her license, and part of what they were tested on is a new study, some new studies on, the progress of labor, and it allows for way more time than this does. So if we're, if the CNMs are following a little different guideline than ACOG, a more lenient one, then, if we could maybe just change that to current standard of practice or current, standard of midwifery care or something like that, because, and I know where you're going with it, but.
So one of the things that made me okay with putting VBACs into the scope was the practice bulletin from 2010. And so linking this in some way to that kind of practice bulletin was important for me to get to that VBAC stage. So how...
Did they say Friedman's curve?
No, it doesn't. That's paraphrased. It doesn't say Friedman's.
I know.
It's just they update their practice. We use this is the word, management guidelines is the way that practice bulletin is written up. So if there were an updated management guideline, then that is the kind of standard that I would be looking to measure VBACs in the field. You see what I'm saying? Because they're different from these other lower risk procedures, and it's important to understand, to know when to make the call. when to call it. So we have to have something to hang on to say, this is how we're going to call it. So I wanted to, instead of having it tied to Friedman's curve, tie it to management guidelines that might come into the future. Now, I don't know of an alternative to ACOG's guidelines. I don't know what else to tie it to, but I also don't want to just tie it to a study, because one of the things about practice management guidelines is that it looks at they look to not just individual studies, and it's the same in public health. You don't make decisions based on a single study that's published, even though the p-value is really, really low. It doesn't mean that there aren't problems with the study. You have to reproduce those studies, and that's usually what the practice guidelines will do, is that, you know, one study shows that you can go off of the curve in this other way and still have TOLAC proceed right and have good outcomes, and then they would do it again and look at it from, and at some point it reaches the threshold where there's an aha moment and it gets into the practice guideline. And that's what I'm looking for, is to be able to tie it to some sort of, when it comes to the VBACs, to tie it to something like that. And if, so I'm open to something else, but I don't want to just say a study in peer-reviewed literature, because then you could just have one study, and there's journals that'll publish most anything. You may, there's a hierarchy to journals, you know what I'm saying? So
I wonder if there's a way to make an inclusion for like a woman's past labor history as well. I mean, one of the things that we love about midwifery care is that it's so individualized. I'm wondering, for a woman who, before her cesarean, had long but safe labors, a midwife could look at that and say, well, this is what labor looks like for you, and thus keeping you at this curve might not be fair, might not keep up with the very good evidence we have about that particular woman.
And that, if we decide to go that way, we may need some assistance with, because again, these are rules that are for licensing and enforcement as well. So then you'd be putting our surveyors on to looking at the past history, seeing if that was true, looking at this one, and that gets where licensing rules get a little bit difficult. So it has to be the minimum standard applied to everybody.
we'll think about that element. How many more slides do we have? Because we're way over,
Yeah,
way
we're way
over
over
what we said.
Still some, probably about 10. Okay. I can go quick. So again, currently the current rules, the curve applies to all deliveries. We're taking that away from low risk, so those will not need to follow that curve anymore. After delivery, we increase the time to deliver the placenta from 40 minutes, I believe, to an hour. They provide care to the infant and mother, and the medication language is exactly the same as in the rules that are currently existing. For prohibited practice and transfer of care, we've clarified the surgeries that were prohibited. Now it says a previous uterine surgery that enters the myometrium and an incision in the uterus, except for allowed as by VBAC. So we've changed the definition of severe psychiatric illness to serious mental illness, and that new definition is per statute. And then we've changed the substance abuse to the new definition per behavioral health. The preeclampsia or eclampsia has been added. Active genital herpes at the onset of labor is now instead of at the first trimester. Placenta previa, we can update this based on recommendation to persisting after the second trimester, Wendy, or placenta accreta. And we've moved heart disease, kidney disease, and blood disease to a required consultation instead of a prohibited practice. Again, the VBACs haven't really changed except for the one that I've bolded. So it's prohibited if there's more than one previous C-section, a previous C-section with a classical vertical or unknown uterine incision, if the delivery is within 18 months prior to the expected delivery, if there have been complications in the previous C-section, if it was due to failure to progress as a result of CPD. Or complications during a previous vaginal delivery after a cesarean section. So they've tried to VBAC before and they weren't able to do it. And then, or has a fetus with fetal anomalies confirmed by ultrasound or in a breech presentation.
That was brought up, if we could define anomalies. I'll make that a little bit more clear for us. And then I know that maybe that could be a consult, depending on what the anomaly is. And also, there was a comment made about if we know the baby has no compatibility to life, if they could still have the birth of their choice. That was something that was discussed instead of prohibited.
I think it's worth being specific about your anomalies, because for those very points, somebody who has an anencephalic may prefer to deliver at home prior VBAC. I mean, I know you're not wanting to put two complicated issues into one delivery. That being said, if you have a baby with gastroschisis, you're going to want them in a home setting, not in a home setting, in a hospital setting, on a prior.
Would you be able to tackle the word fetal anomalies? Because
again, why I'm sitting here is because I'm not thinking about the practitioners in the room and the two that I'm sitting with, which I have great respect for just in the communication of their practice. You have to be thinking about whoever in future or whoever moves here and they're not going to read the law appropriately or the rules appropriately, and or people that don't understand. So you want to fall to the lowest denominator. We're just thinking about protecting patients and protecting babies. That's the only reason I'm here.
We can certainly try. If you want us to, Will. We can come up with a list.
Well,
I mean,
let's talk
okay.
before you do that.
Yeah.
Maybe that could be something the community is
Yeah.
I mean, I could just tell you, we're not. If there's an anencephalic baby and they want to do a VBAC on it, I mean,
we're not going to enforce
we're not
that.
going to. That's not something that's going to be an enforcement action, or you know what I'm saying? I know, and I'm saying that now, and I'm, all right. I just hadn't thought about that. Okay.
You can give certain argument. You can certainly give argument for the opposite, and there will be people that will give that argument. The argument being bleeding head is not present. You're not going to have pressure. Are we putting this undue stress in an environment far away from a hospital on a uterus, and therefore we consider the patient to be at a higher risk? Not that she's going to go to the hospital and deliver an anencephalic by C-section, but she's just at least closer in the event that that happens. So,
yeah, all right.
It may be wise to keep it the way it is. But I certainly understand.
Yeah. Okay.
Okay, for breach, it's a prohibited practice if the client had a previous unsuccessful vaginal delivery or other demonstration of an inadequate maternal pelvis or cesarean section, or currently has a fetus with fetal anomalies confirmed by ultrasound, an estimated fetal weight less than 2,500 grams or more than 3,800 grams, or in an incomplete breech presentation. We've changed the required consultation to where you can get either a written or a verbal recommendation. So if you can call, you need to document the consultation in the client or newborn record. And again, we'll move the refusal of testing from prohibited practice with the required signed informed consent. Emergency measure,
Just to go back to that estimated fetal weight on the breech, what page is that on rather than the PowerPoint?
22. I don't think we've changed that from the beginning. It's right there. It's about
There's no gestational age in relation, so I could get an ultrasound at 18 weeks and meet that definition.
For the breech, the current ultrasound is between 36 and 37 weeks. That's when we say that an ultrasound has to be referred for presentation and for estimated fetal weight of the baby.
All right, thanks.
Sorry. Ooh, I almost broke your iPad. Sorry, can I just go back to VBAC? I just want to second what Julie said about maybe putting something in there that if you've already had one successful VBAC, maybe we can have something in there that you can then qualify, despite whether you've had failure to progress for CPD, which I still have a problem with. But I think I've made a lot of comments on that already.
For emergency measures, we've changed it that the EMS has to be called before starting emergency measures. Now the midwife just needs to ensure that an EMS provider is called in an emergency. That can be delegating it to somebody who else is in the room. We've expanded the emergency procedures. Episiotomies are no longer restricted to midline, and we've increased the number of release of shoulder dystocia maneuvers to include the entire list. That's posted. Yeah.
Just a recommendation on the Jack Meyer maneuver. A lot of us know that as Barnum. So
Okay.
maybe it might be good to maybe slash
To
that
slash it
Barnum.
and put it in, absolutely.
Delivery of posterior shoulder first, yeah.
Okay, yeah, we can add that in there.
Delivery of posterior shoulder first.
That's even better. Yeah, we can change that.
Under emergency measures, is it going on?
Yes.
Just about suturing, we would really love that out of emergency measures altogether. Suturing isn't an emergency, so getting that out of emergency measures, because we don't want to call EMS when we have to suture.
Okay.
First of all, and then, yeah, just the whole thing about suturing needs to come out of emergency. I don't know if it has.
We can take a look at that. No, it's still currently in. The emergency procedures have also been expanded to allow exploration of the uterus for control of severe bleeding and to allow for manual removal of the placenta. And again, the medication language is exactly the same as in the current rules. The new midwife report, midwives are now required to report within 30 calendar days of the termination of midwifery services versus every quarter. It has to be submitted electronically. We sent everybody the link so they could take a look at the report. And for VBAC and breach, you have to report the rate of dilation and duration in hours of the first stage and the duration of second stage in hours.
One comment on page 25. On page 26, it has a birth certificate number, and I haven't done a new birth certificate yet. So are they assigned numbers?
They should be given a number so that we can link, and that may be something we have to link with
'Cause
our
right
thing. We'll take a look
now-
at it.
Yeah, because right now, I don't know of any birth certificate.
They don't come back with you, okay, for a number, okay. We have numbers here in the department. So we can take a look at that. Oh, no. Okay. For client and newborn records, so a record must be established for both the client and the newborn. The client record must contain the informed consent for midwifery services, a copy of the emergency care plan for VBAC and breach, documentation of the rate of dilation and duration, and lab and diagnostic reports and results. It also needs to contain documentation of verbal and written consults, a description of the conditions or circumstances for required transfer of care, the outcome of the pregnancy, and instructions provided by the midwife to the client before midwifery services were stopped. The newborn record must contain the newborn's information, documentation of verbal and written consults, again, the description of conditions or circumstances for the required transfer of care, documentation of newborn screening, and then instructions provided by the midwife to the client before midwifery services were stopped. Then we have our area for denial, suspension, or revocation of license, civil penalties and procedures. The department may deny, suspend, or revoke a license permanently or assess a civil penalty for each violation for any of the following additional causes, and these have not changed since the previous thing. One of the things we did want to explain was the accountability. Complaints for both hospital facilities, for all healthcare facilities, for child care facilities, and occupational licensing can be reported online. They can be submitted in writing or by phone to the department. You can check to see what type of enforcement actions have been assessed against any facility or occupational license by going to azcarecheck.com. The department does follow up on every single complaint that we receive on every single facility and every occupational licensing that we have. And then based on the complaint investigation findings, enforcement action can be taken. And that would be actions against a license or civil money penalties. So you can actually go in and look up to see what enforcement actions, whether you're going to a facility, an outpatient treatment center, you're being treated by a midwife, a hearing aid dispenser, that is all posted on azcarecheck.com. Finally, for the advisory committee is established to review data from midwife reports, examine evidence-based research, and recommend to the director changes in regulatory rules. Based on the feedback, it will consist of 3 licensed midwives, 1 consumer, 1 licensed physician, and 1 nurse midwife. They serve at the discretion of the director of the department. They may serve for 3-year terms and are not eligible for compensation or reimbursement.
So we've been around on that last bullet, so are we good? 3-1-1-1?
We have just one statement we'd like added, that the physician and CNM should have significant experience with midwives and out of hospital delivery.
I would disagree with that because they should be there as a consultant, and you're not going to find that person. But more importantly, can we include a pediatrician on this panel? Because ultimately their patient is involved as well. If we had one more midwife.
I mean, are going to have a fair amount of work to do
I would
before
request
October.
a pediatrician, or at least make that offer. No, a pediatrician is different than an obstetrician.
No, the physician is.
Well, this one says somebody who is experienced in obstetrics. A pediatrician would not be experienced in obstetrics, but their voice needs to be heard.
So
I'm fine with practice. They're not going to find
let's do some horse trading if we can, maybe.
We are totally fine having a pediatrician on there, but I would love another midwife.
Right,
then,
that's
'cause
what I'm
it has to
saying.
be
If we
midwife
move
dominated.
to say,
But at that point, we're not squabbling.
well, no, but see, I know, but I'm trying to get consensus, and right now there's a perception that it would be, 3 against, not against, but I know.
That's the whole problem.
I know.
With this, is that it's already been given the tone of it being adversarial, and it shouldn't.
Which is why I think it needs to have somebody who has experience with home birth, because then they have some sort of appreciation for it. And they should have the same, that OB who has experience with home birth should have the same qualifications as you do, and they should be just great.
But we can't even be,
But
we can't get malpractice insurance, so you're not going to find that person.
And I'm not saying they have to have a home birth or do home births or something, but they have to understand it. And I think our midwives already have physicians that they consult with. And so if they have those already, there are people out there that understand home birth and have an appreciation for it and don't think that it should never happen. Because I don't think that that's helpful to have somebody, have a physician who thinks that this is the worst idea ever. We won't get anywhere.
Well, I don't know that.
They
I
do
agree.
exist.
They have to at least be willing. I wouldn't be sitting here if I wasn't willing and wanting to hear more. I really do believe what I'm saying as far as prior cesarean section and breech. But I think home birth is a wonderful option. I can't provide it, so I applaud those that can. That being said, the midwife doesn't have experience with high risk and or emergency complications, and having that voice is probably valuable.
Right, and I'm saying an OB should be on, like we're doing, but that OB should still have the same knowledge of his or her OB practice, and then have some experience, whatever, whether it's just that they consult with a midwife. They just there just has to be some sort of relationship there, or understanding, or whatever word you want to use. But I don't see why, for me, or any consumer who's going to be on this advisory committee.
I'm fine with that. I would just ask that you include a pediatrician.
Okay, that's fine.
This committee will also, This committee will also be responsible for developing an annual statistical report on midwifery and home births. It'll be due to the director on or before November 15th of each year, with the first report due in 2015, and again recommending to the director changes in regulatory rules pertaining to midwifery. All right.
Do you think we should modify that? In the sense, do you think that, that maybe add in there the October?
Well,
Okay, yeah. Right, and then also we were wondering if maybe we could have a report ready for you by 2014.
I think it's good to leave it 2015 because you have more time. Because some of these things you're not implementing until 2014. I think it's you don't want to, I mean, we're going to be gathering the data, but you want to have more. And, you know, if we're pushing things back, I think it's good to wait till then. But I also think that, you know, one thing that was added in this last draft is that it now says a minimum of these people that are on the committee. And that could look great, meaning there could be more midwives, or that could be that it then becomes not midwifery dominated. And so if you want to leave minimum in there, fine, but maybe add something that says that there will always be a majority of midwives on this committee, because that is utmost important.
Just one note on that. Director Humble, over the years, I have had the honor of being around in the midwifery community, not myself being licensed, but working with midwives and hearing their stories. And in the past, there have been directors that have not been supportive of home birth and midwifery. So when we look at these things of having a majority of midwives on the advisory committee, it's self-preservation and protection, because I don't know how long you'll be the director, and we have wonderful supportive surveyors and department heads here now that listen to us and respect us, but in the past we have had not so friendly professionals in their roles. So we are looking at making sure going forward that we are protected.
One thing that's not been shown up in the changes in the rules and regulations, most healthcare organizations have their own peer review, their own self-regulation. Our midwives don't. So how does peer review, how does ongoing professional evaluation occur? That's not spelled out here because they don't have their own society. I think that needs to be addressed, and it's not going to be addressed tonight, again, but...
Well, yeah. Here's our challenge, is that most of the other 90-10 boards operate off of fees that are enough to manage the system. And, I mean, our fees are $25 times 60 people every 2 years. So we can't really... We have limitations in our ability to act like a true 90-10 board in that respect.
Understand that, but we're still talking about lives. And we can't
Yeah, I know,
abdicate our
yeah.
responsibility. If we're licensing people, we have to make sure that they're adhering to their license. And I'm sorry, I can't buy that we don't have the money to do it. If you don't have the money to do it, we shouldn't be doing it, period. We've got to, if the state of Arizona believes it can license and ensure the safety of people through licensure, they have to back it up, and it's not spelled out here. So I think that's something that your advisory committee is going to have to deal with. But right now, all you get is a retrospective complaint that you review, and yeah, you know, it could cost somebody a license, but the ideal is to get that problem identified before the accident occurs. When you start looking at practice evaluation and are they following the rules, and is, you know, are certain things being done. It's not there now, and I don't think you can abdicate it just because you only have $25.
Well, I know, but we will have much better data. It'll be electronically collected. I think the data collection and analysis potential is going to go way up with this. Having said that, I mean, our whole licensing division is completely funded off of fees. There's no general fund money at all. So, I can't create it out of nothing. On the other hand, if we set up an electronic monitoring system, we'll be in much better position to do regulatory enforcement and compliance evaluation than we are today.
I would just like to address that we do have the Association of Midwives, the Arizona Association of Midwives, and every other month we do have peer review. It's not dictated by the state, but we believe that it's a very good practice, and we do it every other month. Anybody in the association is invited. It's recorded. It's tracked. If there is a bad outcome, if there is something that is hard for a midwife, they can always come to the peer review committee, and we will write an official report. So if the state asks for it, we have official reports. We have forms that are created to do official recommendations, consultations, whatever, within that peer review committee. So there is already set up. It may not be under the Department of Health, but it is completely set up under the association.
NARM also requires, the North American Registry of Midwives does require that we perform peer review.
Okay, well, we weren't aware of that, and that's great, but I think we ought to formalize it. I think it needs to be spelled out in writing what's going to happen, and somebody has to make sure it happens.
Are you saying the advisory committee would ask for so many charts I'm just trying to understand.
Well, I don't, you're ahead of yourself. Think you have to decide who's going to do the peer review. Is it the advisory committee? I'm not sure that that's the right group. But somebody's got to do peer review. It's got to be formalized, and the public has to know when they go online to look up a midwife, if it's blank, is it blank because they're good, or is it blank because there's no data? You know, I think that's the standard that we're all held to in healthcare, and your healthcare providers.
But we do have that, right? We have the enforcement action on the, you can actually go online and look and see if there are any file complaints. But I'm not
Yeah, I can understand what Dr. Northrup's saying too, but maybe something like on the website. On the website, there can be a place where we can have some of this peer review stuff that would be transparent, that the average public would be able to go there, find it, get a link to go there maybe. I think that's a great idea, very important to have quality assurance.
But I'm just trying to think, like, what, like, I don't want to violate HIPAA, you know, it's just like.
Peer reviews HIPAA exempt. It can't be discovered if it's done properly. Okay, let's go back to, we don't have 10% of 5-minute APGARs, okay? And that's ongoing. That's the kind of thing that the peer review people look at for practice and say, that's unacceptable. Half the stuff that we've talked about here for the last 8 months, we wouldn't have had to talk about if the data had been there. You might have gotten a lot quicker and a lot farther down the road if the data was there. There's not good regulation within the midwifery community of even reporting what's required to the state. So you may say that you have it, but it's not real effective. And I'm saying put some teeth in it, put some writing. Advisory Council does that. I'm not sure who the person is that's going to have to look at the charts. Should be midwives, in my opinion. Okay, I don't have a problem with that. But somebody needs to look at it, and somebody needs to be accountable.
I think the reporting is getting better as per this rule change, but also I just want to say the association is happy to work with the department in whatever for peer review. If something needs to be set up, let's work together.
So I just had an idea. So we've got, while I'm broke in the licensing area, and I don't have the ability to fund things that way, we've got a Title V maternal and child health block grant, which comes to our department, which is about a $11 million grant, and we could use some of the resources that we have there to analyze the data and help give support with the advisory committee. Those are some of the resources I have internally to help provide that check into the system. It's not a regulatory body, but it can do that. It can help with the data analysis.
Yeah, that's why. But the state of Arizona does not give any money to Summit Healthcare to do our peer review. They can do their own peer review within their own system. How they fund it is up to them, but it's their accountability. It's their responsibility to do that. And I don't know that the state of Arizona has to pay for it. They don't pay for it anywhere else. They certainly don't pay us.
But they do it already.
But it's set up. It's already being done. So I don't understand what else you want because it's already set up. We are already funding it. We are already doing it. So what else do you want?
Well, I guess why in the reports that should be submitted, why is that data missing?
No, I mean,
So
the
if
point's
you're
well
doing
taken
peer
that-
review, are you not?
I mean-
Do you have that data?
I have it in our.
Or whoever's doing,
But-
not on yours.
So the point's well taken. The Arizona, and I'll put this on the record for live stream and everything, we are not doing a good job doing regulatory oversight of this program. Now, having said that, we've part of the challenges, a big part of the challenges that we face is that the data that we're collecting is not easily usable. So one of the things that I think this system is going to set up, it's going to set up a mechanism where we're going to be able to collect data electronically and be able to quickly identify those midwives that are not submitting their data electronically instead of the quarterly reports, which are on paper, which, I mean, it's just an enormous logistical challenge to provide the regulatory oversight that we should when we're facing quarterly reports and application processes that are absorbing the time at the front end instead of the back end. So what we can do is make sure that we're maximizing our ability to really review this program, and the electronic data reporting is going to be one of the key ways for us to do that. But don't forget, it's the front end of the application process that's been hamstringing us as well, and as frustrating as it is for the midwives to get new licenses, that is all time that gets absorbed by the program on the front end of licensing, and then the back end, in terms of the data collection and analysis and the regulatory oversight, is what suffers because we're dealing with the front end applications all the time. So I think with this new process, we're going to be able to flip that, which will free up time so that we can be a more effective regulatory body, which we need to be. So one of the things we talked about at the second meeting, because I wasn't at the first, was that I wanted at the end of this process to get to at least a grudging consensus about a set of regulations. And when our committee first started, we were very far apart, and I know that there's disagreements even today about how much we've accomplished and whether the regulations are exactly what folks want. And I know there's difference of opinion there. But what I hope to get in the next 10 minutes or so is a feel for each of the committee members. And I thought about how am I going to ask this question. And because of the maturity of the process and where we are right now, I thought maybe the best thing to do is to ask the following question. Now, first, frame this question like this, that the draft rules for public comment would be changing slightly based on the stuff that we talked about today. Number one, the administrative portions of the rules would go into effect on July 1st of 2013. That's the application process, the NARM certification, et cetera. The scope of practice would go into effect on October 1st, and in the meantime, the advisory committee would develop the informed consent protocol around the tests that are that will be in the future potentially declined. And then the other pieces of the scope of practice that would be the VBAC would be July 1st of 2014, along with the portion in the hospital where they have to do the policy procedures around the calling of the hospital at the beginning of labor and after. So with those changes, here's my question. I'll start at the end and we'll work our way back. And so Janice, and I'll ask everybody the same question, do you believe that what we've accomplished, given the modifications I just talked about, do you think what we've come up with is better than what we have today?
Absolutely.
Okay, that's a short answer.
Yes, qualified. Somewhat better.
You can explain your vote like they do over across the
Can I
street.
explain my vote? The VBAC and the breach I can't agree with. I think it's premature. I think there's too much confusion within the state of Arizona. You've got licensure saying one thing, you've got access echoing that, and you've got this committee or this department trying to do a 180 on that. Before you put it in writing, I think it needs to be talked about. I have no problem talking about it. I have no problem with a year's wait of talking about it, but I don't want it guaranteed on July 1/14 that we're going to have a VBAC rule that could be attained. I don't think we're at that point. We don't have the data.
Absolutely.
I agree with Dr. Northrup.
As long as patient rights are totally respected, I'm 100% for it.
Me too. In fact, one thing that we didn't talk about that I would love to see included in these rules is some sort of preamble that everything that comes forward out of these rules are based in the spirit of patient autonomy, the ability to say no, and the protection of the midwife from any sort of prosecution based on her client's choices. That being said, you've done an admirable job in the face of considerable disagreement and adversity. Thank you.
Yes, I just second everything Julie said. I don't need to say it again.
Okay, so we have at least general, although not complete consensus that the rules that we've come up with the modifications we talked about today around the testing are better than what we have today. We've got a couple of members of the committee that believe that specifically that the breach and the VBAC pieces are premature, given the data that we have at least in Arizona. So now I have to decide whether to ask for a motion from you all or just or just, you know, we've got it on tape what everyone said and thought. Maybe just leave it at that. What do you think?
You know, one other comment. You've made it clear, and I think we all agree, that this committee and this department can't change the prescribing laws, but I think everybody at this table realizes that discussion needs to take place, that there has to be some discussion of limited prescriptive authority for CPMs.
Thank you.
Okay, so now we're at a bit of a dilemma. We've used up the entire agenda, and it's 6:30, and we have not got to the public comments.
I would venture to say that a lot of public comment is going to have to do with the consultation issue. So maybe if you still wanted to have public comment, people could consider that these changes are going to be made before they make their comment, and that might take up way less time.
So let me summarize the testing real quick. So what I've committed to doing is asking our team to change the testing so that it is deferred until October 1st, and that it is tied to the results of what the advisory committee comes up with in terms of the informed consent piece. If the committee decides that they believe that the substantive policy statement should, require a consultation, then I'd be inclined to accept the committee's recommendation regarding the consultation. But I'm committing that it won't be a prohibited practice, except to the extent what's already in the current rules regarding the positives, if you're positive. So.
One last thing before we end. With the timeline coming up for October, as far as the committee, are you going to send out an application for people, the midwives to apply, physicians to apply, like you did with this committee, so that will move very quickly?
Well, so our first task is going to be we're going to finish the rules. It's going to be, I want to make sure that we get it precisely the way we described around the 3 different deadlines, July 1st, October 1st, and July 1st to 14, and that we write it in a way that we can actually execute. So I'm not going to divert my staff time on that piece of it yet, but I'll take into consideration the comment about the pediatrician, and I'm sensitive to the balance with respect to looking at what the other 9-10 boards do in terms of the way they operate. And then once we publish the final rules, then after July 1st, that administrative piece would kick in, including the advisory board, and then we would have to, because of our deadline, we'd have to kick in pretty quickly to staff up the advisory board, especially because of the deliverable which we have for October 1st on the informed consent for folks that decline tests. So I do know that that's a tight time frame, and so we'll be as quick as we possibly can to get those. And they're appointed by the director, right? It's not anything else. And we're going to take out at a minimum so that there's no ambiguity in the future about what the makeup of the committee is. So if it's, let's say we add a pediatrician and then add another midwife, for example, it would say, 4, 1, 1, 1, 1, or, and not at a minimum, so you can't stack the deck in the future.
One way to handle that would be to have a standing committee, but also have consultant non-voting. So you could put somebody in the room that has the expertise.
Like ex officio, yeah.
Right. And then you have the knowledge in the room, but you don't have the adversarial.
Right, that's a way of doing it.
How many votes do we have, every time somebody wants to talk?
It's like me on first things first. Yeah, we could do, that's a good idea. We can make an ex officio. Okay. All right. So what I'll do next is just thank all of you for all your time. I know, Dr. Northrup, you've been driving all across the state to come down for these meetings, and he drives home at night. And when we first started these meetings, it was dark when we left, and I remember thinking, holy smokes, he's driving all the way up there. He's going to get home at midnight or 1 o'clock. But, but also thanks to everybody from the committee. I know, like all committees, there's a development phase and a storming phase and then a collaborative phase, and I think we came to a good spot at the end where we've got something I think all of us believe the system as a whole is better, although I know there are elements that are that y'all just completely disagree with respect to breach and VBAC.
We say thank you.
Thank you.
Oh. You know, when you're in this job, a lot of times you take on a sort of a symbolic role more than it's really is. And what this is a team. It's, you know, I'm the director for the state health department, but I'm more like the conductor. I don't really have an instrument. Everyone here in the staff and folks at the department have really poured a lot of effort into this, and I think it's going to pay dividends into the future because we're going to have a better system and a better way to evaluate the system. We're going to have much better data collection. We're going to have some reports that come out to really help us evaluate the system over time, and which will then give us a much better ability to make decisions in the future about, you know, what was the wisdom of the breach in the VBAC edition? We're going to have some data to look at that moving forward. I mean, so I didn't adjourn the meeting yet, but I mean, we could do. I mean, we had time on the agenda for public comment, but we used that time to work through some of these issues. Okay.
Everybody here has been in agreement this entire time that the medication is a huge, enormous health issue. Is there any reason that somebody that is a member of the Department of Health Services, we have several physicians on staff, cannot issue a standing order to the licensed midwives to allow us to carry medication until the statute issue is addressed?
First of all, I'm not a physician, so I can't give a standing order. And you know, I'm not going to answer for my team, but let me just say, to be honest and totally transparent about this, I'm not. I think it's going beyond my role as the director and as people's supervisors to ask them to do something that's a private license of theirs. So I'm just not going to ask anybody to do anything like that. And, you know, if people want to do it, that's fine. That's their license. But, you know, I'm just not going to, if you ask me to ask any of my team to do that, I'm not going to. I won't ask them. I haven't asked that question, and here's the thing about being in this job. Sometimes when you ask a question, people think it's a leading question and that you want a particular answer. So I'd be sensitive about how I talk about things because people think if I ask questions that you know what I'm saying? I don't want to compel even in a well, you know what I'm saying. I don't have to talk anymore.
The one issue is our prescribing rights. We have to see the patients and have a chart on the patients to be able to prescribe anything. So that's an issue that even if somebody wanted to, we couldn't as licensed.
We do have a couple of things that the AAM discussed today. just so you know.
Okay, with that, thank you, committee. I think we've done a lot of good work. Some of you may be on the advisory committee moving forward. I really appreciate the work of our team. And Patty, let's give Patty a special shout out, because Patty's been the person behind the scenes that's really been working hard to create these numerous iterative drafts, and you still have some work cut out for you after today. But thank you for your commitment to this process and for really having such a good attitude about everything that we've asked you to do throughout this process. So thank you. Okay, so with that, we'll adjourn the meeting. Thanks, everybody.